Todd Palmer. I'm one of the faculty at Full Circle, and I am a family doctor and also a geriatrician. I work at St. Al's a couple times a month in a geriatric consult clinic and also addiction medicine doc. And I've got COVID today, so I hope I apologize in advance for any coughing that I might do during this talk, but I'll do my best to get through it. Um, so here we go. So this is my talk is on doing low dose inductions to convert people from full mu agonists to buprenorphine. Um, and our learning objectives are to learn the general concepts of low dose inductions, be familiar with some of the different regimens that are out there, um, be familiar with the advantages and disadvantages of doing this. Um, and we're not going to spend too much time talking about fentanyl just because, we just had a talk 2 weeks ago on that by um, by Andrew. So if we could, you guys will have to advance, right? Okay, so this is most people know this, of course, but buprenorphine is a partial agonist, and so we have a plateauing effect here um, with regard to um, respiratory suppression, um, with regard to euphoria, and we don't see that with the full mu agonists. They just keep going up like this, which make them more dangerous. Um, the other quality that I want to point out is the high affinity of buprenorphine, so that it will knock off full mu agonists. It will knock them off the mu receptor and take over that receptor. So just remember those two key characteristics. Next slide, please. So these are the issues that we face when we're converting a patient to buprenorphine. And we can put people into precipitated sudden withdrawal, which is a very, very uncomfortable feeling for people to have. And the reason that happens is that we give them buprenorphine, and if they have the full mu agonist on board, the buprenorphine knocks that off the receptor and then takes over that receptor. But now we have a partial agonist, not a full agonist. So they're not getting as much of an effect on the receptor. So that puts them into some immediate precipitated withdrawal. What are some risks for this? Well, being on high dose, especially methadone, high dose methadone, a shorter time to the conversion, which makes sense. If you wait longer, then you get more. We would like to have the full mu agonist out of their system before giving the buprenorphine, so that we're really not knocking off any of that med off the receptor. And then for some reason, females have more of a problem with this than males. Methadone is long acting. It can take as much as 96 hours to get methadone to a level where this doesn't happen. That's a long time for people to be off of their methadone. And I have to tell you that in my experience, the only patients that I've actually put into precipitated withdrawal in clinic were people that were on methadone. And they had told me, yeah, I've been off it for 48 hours, 72 hours, but I don't think they had. They don't want to go off their methadone. They don't want to experience withdrawal. And then I gave them the bupe and I put them in withdrawal. Next slide, please. So what are we doing with low dose induction? What we're doing is we're starting off with very, very low doses of buprenorphine and just enough to knock a little bit of that full mu agonist off of the receptor. So what we're doing is each day we're titrating that dose up a little bit, and we're knocking off a little bit more of those full mu agonists off of those receptors and taking over those receptors with buprenorphine. The advantage of this is that people don't have to go through withdrawal at all. Normally we have people get off their meds, come into us in withdrawal, and then we induce them with buprenorphine. With this method, they don't have to go through withdrawal because we're actually continuing the full mu agonist, but giving them buprenorphine on top of it to knock that full mu agonist off of the receptor. The other advantage of this is that if they're also taking that full mu agonist for pain, they don't have to experience a period where they have pain from not being on the opioid. Because again, we're continuing the full mu agonist, we're treating their pain, and then we're gradually taking it over with the partial agonist, the buprenorphine. A really key advantage of this is that another advantage is that you can do this with patients that are on higher doses of methadone. Normally, when we are wanting to convert someone from methadone to buprenorphine, we taper them down on the methadone to 30 milligrams, maybe sometimes a little higher, but definitely, definitely 40 or less, but usually 30. It turns out that 30 milligrams is really not an adequate dose to prevent cravings. And it's a subtherapeutic dose to treat craving in opioid use disorder. So it's a very precarious time where they might go out on the street and get something. Next slide, please. Next slide. So this is basically what's happening, right? The buprenorphine are the little blue things, and they are gradually knocking those full mu agonists off of the receptors. So you can see day 1, day 2, day 3, day 4. By day 4, they've pretty much taken over the receptors. Now, I will say that we usually do this over longer than 4 days, and I'll show you the regimens in a little bit. Next slide, please. So again, what do we typically do? We taper them down to 30 methadone. We keep them off the methadone completely for 36 to 72 hours. And then we start giving them low doses of buprenorphine. I'm not talking about really low like we're doing in the method I'm talking about today. Usually we'll go with like 4 milligrams, sometimes 2. But as you'll see in the regimens that I'm going to show you today, we even use much smaller doses than that. We're using like 0.5 milligrams. They actually, how did they even come up with this idea of doing this, of doing this like super low dose induction? Well, they looked at people who were successful in being induced with buprenorphine, who are on methadone, and people who were not successful. And believe it or not, it turned out that when people are given buprenorphine in the first 24 hours, they seem to do better than that's 24 hours after being off the methadone. That's kind of counterintuitive to what I was just saying about, precipitating withdrawal. But some of the folks, if they gave them, lower doses of bup, and they had been on the methadone for, the bup was given the first 24 hours, there's actually a higher success rate. So then they thought, well, geez, maybe we should just keep the methadone going and use super low doses of buprenorphine, and maybe that'll work better. And that's how this whole thing got started. Next slide, please. So as you're going to see in this lecture, there's a lot of different regimens. None of them are really well standardized or well tested, but it's all the same concept. It's using very, very low doses of buprenorphine and titrating them up slowly over, usually a 7-day period, however, sometimes shorter than that. And they take over the receptors. Now, there's been some debate about what do you do with the full mu agonist while you're doing the titration of the buprenorphine. Back when they first started doing this, people would taper the full mu agonist while they were titrating upward the buprenorphine. But I think most folks now are just continuing the full mu agonist for the whole time at the same dose that they were on before you start doing the induction. And what that just kind of it keeps the picture kind of clear and doesn't muddy it, backing off on the full mu agonist or giving them too much buprenorphine. So it says my internet connection is on. Can everybody still hear? Okay.
Yes.
So I think what most folks are doing now is continuing that exact same dose of full mu agonist while they're up titrating the buprenorphine. Next slide, please. So what does a typical regimen look like? And again, there's a lot of different ones out there, but Um, this is one that I use, and as you can see, zero point 0.5 milligrams day one, zero point 0.5 BID day two, 1 BID day three, 2 BID day four. Um, um, let's see. Oh, I'm sorry. Just two, yeah, two BID, 4 BID, um, day five, um, 4 TID day six, and then day seven, um, you can go with 8 BID and then stop the full mu agonist. Now, what should be your target dose for the buprenorphine? You hear different target doses, but I'd say somewhere around 12 to 16 would be your target dose. And then on day seven, again, you're stopping the full mu agonist. Now, you don't have to march along and do these increases every day. Um, let's say let's say it's not going that smoothly and someone's having some difficulty. You can continue on, let's say, 1 BID for an extra day or even more. Um, I've heard about this regimen being used with people that were on, very high doses of methadone, like over 100 milligrams a day. And when you're on those really high doses, it may require more than 7 days to do this. So it just doesn't have to be, very regimented. You can take longer than what's written here. Next slide, please. Um, yeah, here's just another similar one. Here they went up to 12 as the target dose. So again, as you can see, same principle, um, just slightly different. Next slide, please. Um, Now, this is when you do this, you want the patients to be on a predictable dose of their full mu agonist before you do it. You don't want to do this when they're having like an acute pain episode, if they've just had surgery or they had an ankle fracture or whatever. You want to be on a predictable, stable dose before you do this, because as you can see, these regimens they're not simple. Um, and one of the disadvantages is that patients need to follow these instructions and take, the prescribed amounts every day. And, it could be a little complicated. So we don't want to complicate it more by having varying doses of that full mu agonist. And, don't forget about adjunctive meds. If they do have some withdrawal, you can use adjunctive meds. Um, and then I talked about the last bullet point there already. Next slide, please. Here is just another regimen. And next slide, please. So you can do this more rapidly. Let's say you're trying to get someone induced while in the hospital. You can do this over, this is over uh, a 3-day period. And as I'll talk about a little bit later, like if someone's going to stay on their fentanyl, you don't want them to be getting fentanyl very long on the street. So you might think about doing, like a 3-day induction, or make it a faster induction. Next slide, please. Here's over 24. I put this, not totally sure about this. I've never seen anybody do this, but I know it is done. And I just wanted to put it in here as a reference. Next slide, please. So, if you're in the hospital and you ask the pharmacist to give 0.5 of bup, they might say, I don't feel comfortable breaking a 2 milligram pill into quarters, and having that to be exactly 0.5. So they might balk and not do it. So one thing you can do is, instead of using the pill, you can use a patch. So the transdermal patch, this is, these are low doses. The transdermal and the buccal patches, buccal form, is low doses of buprenorphine, and that'll allow you to deliver 0.5 in a day, without having to break pills. The highest dose patch is 20 micrograms per hour, and if you do the math, that's 0.5 milligrams of the equivalent is 0.5 milligrams of sublingual buprenorphine daily. Um, why don't we do this more in our outpatient setting? Well, patches are expensive, and the pills are cheaper. Um, the other thing you should be aware of is that um, the patches and the buccal forms are not it's not okay to use these to treat opiate use disorder. I mean, not even off label. Um, however, people do this all over the country. You're not continuing them on the transdermal. You're just using it to start the induction, for a day or two. And the DA isn't going to come after you because you've used transdermal for a day or two to do an induction. You're not doing it on an ongoing basis. And I personally wouldn't worry about it. And I don't think anyone else does either. Um, Next slide, please. These are just some doses, some equivalent doses. Um, you can see the transdermal 20 milligrams equals 0.5. Buccal film 225 micrograms equals 0.5. And there you have some of the disadvantages and advantages here. So I wanted you to have this as a reference. Um, Next slide, please. So this is a sample transdermal regimen where you're giving 20 on the first day, and then um, and then on the second day you can add um, you can add the sublingual. Um, you don't have to. Again, you can give them the transdermal for 2 days, but typically people add transdermal on the second day if they're doing okay. Um, and I'm sorry, they'll add the sublingual on the second day. Might continue the transdermal. And then they go forward without the transdermal, but just the sublingual. Um, or stop the patch a couple of days into it. So, giving the patch, probably for 2 days, maybe three. Again, it's a pretty low dose, so it's only 0.5. Next slide, please. Here's just another faster protocol using the patch. Next slide, please. This is a protocol using the buccal preparation. And here you know, the problem with buccal is you've got to give it, 4 times a day. It's got to be given every 6 hours. Um, uh, let's see, at Eli Harris, I'll have to get to that question. So it's 150 every 6 hours, day two, 450, and then you're starting on um, sublingual. I should have put sublingual, not orally. We don't swallow buprenorphine pills. They're taken sublingually. You don't get very good bioabsorption when you swallow them, and people seem to have more side effects like nausea when they're swallowed versus when they're taken sublingually. Next slide, please. So fentanyl. Um, Boy, I don't want to spend too much time on this because again, this was just covered um, last week. Uh, but um, the challenge this presents, so let's say somebody's on fentanyl and you want to do an induction. You want to do, we're gonna look at other options, all other options. But if we've exhausted other options and you're still thinking about doing low dose induction while they're on fentanyl, it's a little dicey, right? Because you're saying, um, yeah, it's okay for you to keep getting fentanyl from the dealer on the street while I'm doing this low dose induction. That's pretty dicey and um, not something we really want to condone. And if you do that, you want to say, hey, other options were discussed and exhausted, and this is what we're going to be doing. And you want them to take that same dose of fentanyl as they've always been getting, and you likely want to do your low dose induction faster than 7 days because you want them to be getting the fentanyl on the street for as few days as possible. You can, if you're working at a methadone clinic, then you can convert them to a stable dose of methadone before doing the induction, and then go methadone to buprenorphine versus fentanyl to buprenorphine. If they're having pain, then and it's a very reliable patient, then you might say, well, you know what? No fentanyl, but maybe I'll give them MS Contin, and then I'll do a conversion from MS Contin to buprenorphine. But again, risky, a little dicey because we want to be giving them MS Contin when they might be also be getting fentanyl on the street. But again, it depends. It depends on the patient. Um, um, I think I said everything else here. If you're doing you as was stated 2 weeks ago, with fentanyl, there is the macro induction option as well, where you just start them out on like 16 milligrams of bupe, and people seem to do pretty well. The evidence, the incidence of precipitate withdrawal turns out to be quite low. So that is an option that I think more and more folks are doing versus doing this low dose induction and having them continue to get fentanyl on the street, which again is kind of dicey. Um, um, if you are doing this, there's you want them to have Narcan. You want always patients to have Narcan. And there's a never use alone hotline number that I've given as a reference at the end of this presentation. Next slide, please. So, let's say you're doing this in the hospital, and they're addicted to opioids. You can keep the opioids going while you're doing, um, uh, while you're doing this low dose induction. Normally, we're not allowed to continue full mu agonists to support or treat's not the right word, but to support an opiate use disorder, right? I mean, that can be done with methadone at an opiate treatment program, but that's a very, regulated environment. But otherwise, if you're not in an opiate treatment program, you're not allowed to continue to prescribe full mu agonists to support an opiate use disorder unless you're treating pain. But if they're in the hospital, you can. And apparently there is an exception that the DA will make where you can apply to give them an additional 3 days while you're doing your low dose induction. I've actually never done this, and I think this still exists. I don't know anyone that's applied for this. I don't know if anyone has any information on this. Kathy, have you ever heard of this, or anybody else?
I have not, Todd.
Yeah. Um, I don't know. Um, yeah. I mean, I don't I don't know when this would ever come up, to tell you the truth, because normally people come in and they're either getting methadone or they're getting something on the street, right? And if I'm prescribing the opiates to them, then if I'm prescribing fuel agonist, then I also have to be treating pain. I can't be just giving them to them for an opiate use disorder. So I don't see where this would come up, but maybe I'm missing something. Um, next, next slide, please. So what are some of the tips to succeed in doing this? Well, you want to be in close contact with your patient. These regimens are a little tricky, and they might need some help in following them. So, phone calls, daily phone calls, dosing guides, setting up pill boxes is a nice way to go. And as I've already said, if they're go over 100 methadone, you can go slowly. Um, this is also a good thing to do if someone might have been through opioid precipitate withdrawal in the past, and they're very afraid to do an buprenorphine induction, and you can tell them, hey, we've got this method now that you don't have to go through withdrawal. So they're afraid of withdrawal, they don't have to go through withdrawal. Also, if they have pain, you can tell them, hey, you're not going to have to go through pain. Now, I'm glad we have Nina on the phone on this call, because what if you're doing this and someone is they're being treated at Raise the Bottom with methadone, and they're coming to you asking you to get them on buprenorphine, and you're considering doing a low dose induction? Well, it's probably good to have, I mean, it is good to have communication with the methadone clinic while you're doing this. I don't know if you can shed any light on this, Nina. If if an outside provider is doing a low dose induction, they're going to your clinic and getting methadone. I'm sure you want to be aware of that.
Yeah, absolutely. I can talk about it now or even more in the discussion. Um, I think, one of the major things to consider is that period before you're actually starting the low doses of buprenorphine, right? So, most patients are on, 80 milligrams or 100 milligrams, of methadone. I would say the average is somewhere around there. So, it's less likely, fewer patients are on lower doses of methadone. Even the average dose is, you know, maybe somewhere between 80 and 100. Um, Especially now with the fentanyl, the average dosing is kind of going up. But so something that's really significant is that portion where we're weaning them down to the 30 milligrams, right? That's a big deal for patients, and it's kind of an involved process. Um it usually does present pretty significant withdrawal symptoms, and a lot of patients are unable to kind of even go through that period before they're able to get down to the 30 milligrams, which is what we recommend as well. But when you do get down, so we kind of do the portion where we're weaning the patients down, to 30 or 60 milligrams or somewhere in between. And then, yeah, one thing to consider is that if you're getting prescription Suboxone or buprenorphine from another provider and you're enrolled in an OTP or, an opiate treatment program, it could be considered an illegal thing because you're dual enrolled in a program. And so we have to be involved with the patient. And so there is some logistics where the patient has to get the prescription from the other provider and then work with us as they're lowering the methadone, even those last few bits. So yeah, definitely some considerations.
So one thing I'll add to that is if you're doing the low dose induction, um, supposedly uh, the advantage is you don't have to taper them down to 30. Um, you can continue them on the dose they've been on, maybe whether it's 80 or 100 or sometimes even over that. If you're doing the typical induction where you're having them stop the methadone for 36, 48, 72 hours, yes, then you want to get them down to 30. But with the advantage of doing this is that they don't have to go through that tapering. Um, I just want to make sure everybody's clear on the fact that, like, let's say I have a patient going to the methadone clinic and they're saying, I want you to handle this, doctor. I want you to prescribe my methadone and and do the low dose induction. Legally, I can't do that. I just want to make sure everybody knows that. Like, I can't do that because I'm not an opiate treatment program. Um, that is probably going to change. I mean, right now there's legislation in Congress whereby addiction medicine specialists outside of OTPs will be able to prescribe methadone. But that's an active deal right now. But having gone to the most recent ASAM conference, American Society of Addiction Medicine, they're optimistic that that's going to change. So stay tuned on that. Next slide, please. So just to finish up, I think I went a little bit over. Sorry about that. Um, the pros and cons: you avoid withdrawal, you avoid significant pain. It might be more acceptable to patients, especially if they've gone through failed inductions and gone through withdrawal in the past. Um, Again, it works better on patients on high doses of methadone. Um, um, it might work better with synthetic opioids with unpredictable clearance. Um, that's another touted advantage. Regimens can be complicated. These are the cons, and it takes longer. Than a typical induction. And then I'll also say that, once you get them on that dose of buprenorphine after they stop their film agonist, you don't have to stay at 12. You don't have to stay at 16. You can adjust that as needed, depending on their withdrawal and most importantly, their cravings. So that's all I had. Thanks for clarifying things, Nina, and your input. Um, oh, these are just some other tools. This is a shared decision-making tool. on starting buprenorphine. Can I see the next slide, please? And this is, I don't know if you guys are aware of this never use alone number. Um, People, no matter what they're doing, shooting up heroin, taking fentanyl, whatever, they can actually call this number and have someone on the other end to make sure they're okay. And any patient can do this. This is harm reduction. Next slide, please. Okay, and I think that's it. Does anybody have any questions?
Did you want to answer the one that's in the chat? Outpatient patches only come in packs of 4 for pain. Is this the case for you? Kathy did say that she only sees it in 4 pack.
Are we talking about the buccal or transdermal? I think it was Eli Harris that asked that question.
Yes. Like, could you clarify that?
Yeah, sorry, I was muted. Transdermal.
Um, yeah, I mean, you're not going to need more than four. You're only going to need, you only do it for the first couple of days, so you could probably get by with two, maybe three. So you won't need more than four because you're only doing the patch, those first couple of days, and then you're going forward with the sublingual.
But I just think they'll just have to get at least four,
Oh, I see what
just
you're saying. I see.
multiples.
I'm sorry. Oh, so they'll have to pay for four. Bummer.
Yeah.
Yeah, bummer.
Yeah.
Because
Oh
they're not
well.
cheap. And again, I haven't done this on outpatients because it's expensive. The only time I've thought about doing it was when the patient was in the hospital. I mean, with my outpatients, I just say, get the two milligram pill or get the strip and just cut it in quarters. Um, and if even if it's not exactly zero point 0.5, that's still okay. But I think the pharmacist, medical legally in the hospital, they don't want to say, hey, I'm giving them exactly zero point 0.5 when actually I really don't think I'm not confident that I can break this in exact quarters. So that's where they get hung up. But for my outpatients, I always just have them cut the strip or break the pills. Um,
Does anyone else have questions, comments? Nina? I saw your
I was just gonna say thanks for presenting that, Todd. Yeah, that's it. It's a really interesting protocol. We haven't done any well, I haven't done any. I don't know if there's, two other nurse practitioners there, three, who are also seeing patients. But I haven't done anybody who hadn't been weaned down. Um, you know, certainly less than 100 milligrams. So that's really interesting. You guys are doing this inpatient and you've seen success with it with patients not having withdrawal symptoms?
Inpatient. I'm not doing inpatient anymore, so I haven't, but I've done it a number of times outpatient, Nina, and people have done quite well, to tell you the truth. I mean, not everybody, but I would say the majority of the patients I've done this on, and a lot of folks are like moving to this, like they're not doing um, regular inductions anymore. They just see there's too many advantages in doing this, and that's what they're doing. Um, so I don't know if Jake Harris has any comments on this, if you've done this inpatient, Jake, or what your experience has been.
I've seen a lot of variations of this done on the inpatient setting. I kind of agree that it's hard to do this when they're on fentanyl that they're getting on the streets, and so the more likely thing that I end up seeing is someone coming in on fentanyl and they've used recently enough that the decision becomes, do we do the low dose induction without their continued use of the fentanyl? Do we do a macro induction or do we wait until we can do a regular induction that we would normally do? That's what I've run into a lot more. I've been waiting for the case where someone will come in on methadone and be in the inpatient setting, or where we would continue the methadone and do the cross taper. I think that it's going to be incredibly effective, but I haven't seen that yet on the inpatient side, or in the rehab side. I have not done that.
So you've had patients who were on fentanyl, came in and didn't give them any additional fentanyl, but did this because the assumption is they're continuing to seep out fentanyl from their adipose tissue.
Right, right. And
Yeah,
then we have that discussion of how are we going to get this medication started without us in the hospital giving more fentanyl.
yeah, yeah,
It's been offered to patients in the outpatient setting, who are worried about coming off of the fentanyl, as a low dose induction, but the majority of them have chosen to actually do a high dose induction instead of going
yeah,
back to use fentanyl, which is absolutely safer.
yeah, yeah, yeah. I think more and more people are doing the macro inductions, um, and I'm sure if you're doing this with them not being on the fentanyl, yeah, then you'd really want to do it. You'd want to do a fast one, not 7 days, but 3 days to really
Yeah,
ramp them up on the
exactly.
buprenorphine.
Does anyone else have any other questions before we move on to the case?
I have a question. When I first started hearing about low dose, it seemed like, at least my perception was that everyone was on the low dose train. There's a lot of hurrah around it. And then all of a sudden, it seemed like, I mean, this included, there's been so much backtracking almost, this fear disseminated among, and does anyone know what changed and how it changed? Was there some key, like, sentinel event or?
Well, I'm not sure that it's changed that much, but I think if it has changed, it probably has. That probably has to do with with fentanyl. With so much fentanyl being out there, and it just it just seems a little daunting with fentanyl. Especially if they're continuing to get it on the street, and you have to worry about the Adipose stores, and with people really moving, a lot of people moving towards the macro inductions and finding that there's really much lower rates of precipitated withdrawal than we had thought. Um, I've listened to ER docs give talks on this at ASAM, and they say, yeah, like I see physical signs of withdrawal. I hit them with 16 of bup, if they're on fentanyl, and they usually do pretty darn well. So, I think maybe that's one of the reasons that it's not done as much, but I don't think people are off the train so much. I mean, I think it's still being done a lot. Um, and but if it's not, it's probably because of fentanyl.
I think it's interesting. That's kind of been my experience as a provider with the method. And for me, we started talking about this and doing this really before fentanyl was a big, huge issue. And we were doing the method where we would wean down patients to, somewhere between 30 and 60 milligrams and then do the cross taper. And we we really weren't getting as great of a success that we thought we initially would. And I think, a lot of patients were going through withdrawal, having to go, down on their methadone. And even still through the process of the cross taper, they were very uncomfortable and they were craving and having symptoms. And then I think Todd's absolutely right. Fentanyl does change things considerably. It's been my clinical experience that a lot of patients who have been on Suboxone to treat fentanyl use disorder have not been as successful with buprenorphine as they have with methadone. And so, I don't know if there's some degree of that, but I think there's kind of several factors going on. But I've experienced that as well.